Yeah. So in general, yeah, in fact, in the exam, they say go contralateral because that, but again, you go patient by patient. If it's only like localized in the thigh and the groin area is fine and the vein is good, then you can go to ipsilaterals, but I mean, you make your decision at time of surgery. But as you said here, the problem is that he already has a delayed ischemia because he underwent an abdominal surgery, splenectomies, and expelled laparotomy, and now he's left like an hour or two to do like the orthopedics. So it's too long, ischemia time. I don't want to prolong the patient, surgery more, especially he's not stable. He's still in vasopressor, BHT 7.2, which is acidotics, So I think, yes, the best way to put a shunt, get him stabilized and bring him back later, include definite treatment. I think it's the best option. I agree with that. Anything else? Most probably I will do fasciotomy for this guy at the same time because it's been a long time. So most probably if I will do fasciotomy for this patient, So let's see what's the options. There you are. You can go through them, Hamad.
Yeah, so I recanalized the occluded superficial femoral artery endovascularly and placed a cover stent. I don't think it fits.
Why is not a good option here?
Yeah. So
because you have part of the arteries missed.
It's missing,
it's
yeah.
not like
we have
missing is a trauma.
Yeah.
So you have like a rupture vein or artery. So it's not a good option. So endovascular. Endovascular is good if you have pseudoaneurysms, tear, extravasation. But when you trauma, you see like a piece is missing.
Yeah.
Then you don't know. It's just a thrombosis or the artery is already cut, especially you have a sharp, displaced fractures, so you cannot tell. So endovascular is not a good option. And the second thing is that most of you need to put a stent, and it's not good to put a stent when they have an infection. So there's two reasons why we don't do that here. Okay, Next one.
Yeah, expose the injured artery and place a temporary shunt until definitive treatment can be done. Okay. I think this is what we choose. And right. C, expose the injured artery and use contralateral great saphenous vein to bridge the arterial stump. This is, if the patient is more stable, I think I will do this, plus the fasciotomy, sure.
Correct.
And D, perform an above knee amputation. I think this is more of aggressive management, and I will not choose it.
Unless he has like a tissue loss, major tissue loss, nerve injury, then yes. But in this scenario, it's not. Yeah. Okay.
E, expose and ligate the injured artery, perform a prosthetic bypass to below knee healthy popliteal segment. I don't think this is a great answer, especially if we have a better answer before. Plus the prosthetic graft with the trauma, it will be infected and high risk of infection. Plus below knee bypass is bad also.
Correct.
For this patient,
the artery you can see it above the knee is nice, so no reason to go below the knee. So all doesn't sound okay. So again, the best way is be unstable, but a shunt. If it's stable, just use a vein graft, It's easy. They always get you contralateral legs, There's an exam. In real life, you go patient by patient, okay?
Okay, sure.
But Sam, you want to take next question?
Okay. In a patient presenting with chronic limb-threatening ischemia, a risk factor for primary amputation?
This is really a stupid question. I don't think you need to know that. It's not important, But we just go through them but it's not a good question. So what is saying that in which scenario you patient have a higher chance of limb losing amputation than revascularization? So first, access vascular surgery care wrong, because if you have an access, you must end with a bypass. The only time when you are in a rural area, you have a vascular surgeon, then you have a high chance to end with amputation, correct? So this is wrong. Caucasian race, all of them, we know that for some reason, African Americans, they have a higher chance of amputation than white, Caucasian race. So this is also wrong. Commercial insurance, for some reason, if you have a good insurance, most likely people will have willing more to go and spend time and, do a bypass to salvage the leg than patient he has no insurance, self-paid. So if you have commercial insurance, very high chance you may end with salvaging the leg. Low income, I think this is a problem. If you have low income, no insurance, homeless, unfortunately, it's a bad reality, but it is, especially in a state, higher chance you may end with amputation. Care teaching hospital, of course, teaching hospital always, they are more like King Faisal, they are more like, the more like teaching hospital, they are more like, science-based teaching, so always get the best care. So if you were to choose, you choose a D, but I think it's not a good question anyway, so don't worry about it, So let's go to the next question, Bassam.
Okay. Next, okay.
Yeah.
The rationale performing Achilles tendon lengthening in conjunction with transmetatarsal amputation. We don't do, maybe this is for
we don't do it really. The reason why we don't do them, because most of our patients unfortunately don't walk, and I mean, rarely I see patients with transmetatarsal really, they walk very well, I mean, the problem is, you see, when you do transmetatarsal amputations, like when you do like below-knee amputation, the stump will go more posterior, right? Because the posterior muscle has muscle. The same as the foot. When you cut it, it doesn't stay the same. Always you have a chance to go equivalent, like lateral, because the muscle is stronger on the lateral than the medial aspect. So if you look at the foot, they always have a foot to see after transmetatarsal to go more lateral, and this is, can cause, if patient really active and walking a lot, can cause ulceration medial aspect. The reason why they do, they elongate the Achilles tendon to prevent that.
Okay.
So also it is, I mean, we don't do it. Maybe we should consider maybe something we have to learn it if we see patient like that. And I think I saw maybe patient like that, you see like a severe equinox, then this is what we need to refer him. So this is something we can learn from it, So this would be the answer. Valgus opposite. No, usually get an equinox outside, lateral outside, not medial. You get lateral deformity. Pressure on the pedal bypass, nothing to do with that. Non-weighing doesn't matter, improve basoptic pain. Come on, it's not a good question. Well, Sam, we stuck with you. Let's go to the next question.
Lucky.
Okay. Let's see. Here we are. Here's a good question.
Fine.
All right.
19 years old, healthy and physically active man presents with a history of right calf claudication over the past few months. He has intermittent numbness and paresthesia in the foot. On physical examination, he has palpable dorsalis pedis and posterior tibial artery pulses, which disappear with plantar flexion of the foot. MRI image of the right knee is shown in figure. The most likely diagnosis, I think we are talking about entrapment or chronic compartment.
Yeah, I always ask, like, I don't know how many questions you ask. Keep asking about this question. I think this maybe is the fourth or fifth question we get about entrapment syndrome. And the moment you see young people, healthy, active, and intermittent claudication, this is the first thing you need to think about it, to make it very, very easy, And heat MRI, you need a good, really, somebody with an MRI, very good.
Like,
so your diagnosis will be entrapment syndrome,
medial
correct?
gastrocnemius said, yes.
Yeah. So let me get more question, we're going to make it more difficult to ask you what types. We have like 4 types. Some people say put 6 types, What's type 1, type 2, type 3, what's type 1. So really, guys, you need to read for entrapment syndrome because it can give you a lot of questions about entrapment syndrome because they like it, you know. Because always in the exam, most of the time they get you a question which you don't see most, you know. So it's type 1, it's type 2. They give you maybe a scenario where the MRI is the muscle has more lateral displacement with or the they give you like different scenario for different type, and they ask you what type of the entrapment syndrome, you know. So this will be the questions, you know. All right, so this is also an easy one. All right, that's enough for you, Sam. You get all the easy one. Let's go to Ahmed.
Okay. A 50-year-old woman presents with a few weeks history of a dry gangrenous second toe.
Okay.
She has long-standing history of diabetes and is on hemodialysis. Her ankle pressure is falsely elevated due to calcification and toe pressure less than 30. Okay. An angiogram of the left leg is shown as in the pictures. The most appropriate management is?
Okay, well, let's see what's the angiogram. Okay, here you see only the profunda. You don't see SFA occluded,
Yes.
correct? SFA occlusion, flush occlusion, complete occlusion. SFA is occlusion, popliteal is occluded, everything is occluded. You go here below the knee, everything is occluded, nothing. See calcification here in the artery. And then here, the last one, what do you see? You just see small posterior tibial artery. You see it?
Yeah, I can. Oh.
Yeah. And there's calcification here. See this calcification, okay? So
Yes.
what we have is really SFA, popliteal, tibial artery occlusion, except for patent posterior tibial. Okay?
Okay.
All right, let's go back to the question was, so he's 50 years old. He has a dry gangrene. Yes, he's diabetic and hemodialysis. This is the worst scenario. When diabetes and hemodialysis, the worst combinations. They always increase your amputation rate if you have diabetes and hemodialysis, because hemodialysis affects the small artery. Even sometimes successful bypass, still the ulcer will not heal. So anytime you see diabetes and hemodialysis, it's not a good combinations, you know. But anyway, you have to try your best. His ankle pressure is elevated, but toe pressure is 30. You know what the normal toe pressure should be? Should be above 70. This is a toe pressure should be. Okay, so this 30 is really low. Okay, so we have a low toe pressures. And so what do you think we need to do for this guy? He's 50 years old, he has a tissue loss, he has SFA, popliteal, tibial occlusion, only has posterior tibial is open here. So what do you think the best option for this patient?
Okay, the choices.
Vascular or surgery? You see, within the vascular, it's too long, you know. I will not even try that because flush occlusion, popliteal. So most probably we're going to do a bypass in this patient, you know. This is the only way you can salvage his legs, especially he's a young guy, you know. So when you do bypass, it's going to be from the femoral to the posterior tibial because the only two arteries available. So really you need a good vein, you know. If you don't have a good vein, then you have to look for alternative vein. If you don't have an ipsilateral, we go to contralateral. If it's not, maybe you can use small surveillance vein, arm vein, we talked about it before. Or in bad situation, you still can use prosthetics, you know, for limb salvage. So this is what I will do with this patient. So this one I will not even try in the vascular because it's too long, you know. If it's like a occlude from popliteal down, I understand this phase open, but like this one, flush occlusion, very long occlusion, I will just go directly to femdistal bypass. So let's see what option. These are one by one.
Toe amputation.
What about doing toe amputation alone? Is it enough? You think the wound will heal?
Never.
Because pressure is only 30, so it will never heal. So this is wrong. Okay.
Percutaneous balloon angioplasty intervention? No. Long segment occlusion.
Very long. Yeah. So, you know, I'll not even try that. Okay.
Femoral posterior tibial bypass, single segment, great saphenous vein before toe amputation. Yeah.
Looks very reasonable. Okay.
Then above knee amputation, this is too much. And
It's not really
artery.
too much. He may end with that, but at least we
You
gave
might,
him
yeah.
a chance. I can tell you with these pictures, you know, still they may end with above the amputation, but at least we give him a chance. Will not be we never do a primary amputation. We do first bypass. If it's failed, then you can think about it, but it's not a first option, of course. Okay.
Arterectomy with distal filter to protect runoff vessels. There is only one run.
They don't want none of them. They showed any study showed atherectomy is better than balloonoplasty. Anyways, in the vascular here is out of questions. You know. Let me, Doctor. I think I saw Ali was asked. Ali is still here. Or he left. Dr. Ali, are you still there? No, I think he may have already left. All right. So again, this is guys, but let's go back to a couple of questions here. You see the classification. This is for second year. Muhammad or Bassam. This classification here. If artery is calcified, can you still do bypass?
Yes.
How is artery is very calcified? How you do it? You still can do it?
Yeah,
You might
you
need to
mean-
do endarterectomy.
No.
You mean regarding
Because I want to say that to me, this is the whole artery. Artery is 2 millimeters. And then it's not an intima. This is a wall. So the calcification in the wall. So yes, you can still do it. You know. So if you have a calcified artery, you can still do it. And the study showed the patency is really the same if artery calcified or not. So will not decrease your patency. The only problem is a couple of technical things you have to learn about it. First, you cannot clamp these arteries because it's very calcified. If you clamp them, you crush them, you know. So you know what we use for this one?
Use Fogarty catheter.
Yes, but it's difficult. But some no, artery is too small and going to be in your way. I don't think it's the best option. A vessel loop will not get it, will not, because calcified artery will not able to get, and you're doing a small anastomosis, so any small oozing would be really very difficult.
Yeah, you just do it quickly.
I get liposuction for you. Yeah, I can.
Yeah.
No, it's two-way. First, there's like a block intravascular. We used to use in Faisal. You put it there, it's like kind of a glue. It disappears by itself in about like 30 minutes, you know. We used to have it, but I don't think we still have it anymore. But you can put like a glue, so you can close the artery from inside, and it will dissolve after 30 minutes. The other thing which I usually use, I go to the cardiac, because this I learned this technique from the cardiac surgeons. I don't know if Muhammad was out here, the cardiac fellow. I don't know if it's here. Anyway, they use CO2. Like, see, when they do coronary, they don't want to clamp the coronary artery. So they get the CO2 blower. They get the CO2 and they have like a suction and they blow CO2. So when you blow CO2, it pushes the blood out. So you can see until you put your anastomosis. I think this is the best way and it's available. So you just go to the cardiac people, tell them I need a CO2 blower. And when you do that, get your assistant to blow up the area where you're doing your anastomosis. This will push the blood away and you can do anastomosis. I think this is the best way because you don't want to clamp. Because the moment you clamp and crush it, especially distal, then you injure your artery. Then your anastomosis will go, you know, to drain. Second thing is that when you sutures, you have to really push hard, you know, because you are suturing against the calcifications, you know. So you just have to hold the needle from the middle and really push hard, slowly until you get through the artery. So you can still do it, you know, you just need some, you know, technical issues. So again, use CO2 blower and you be hard when you do calcification. Sometimes if your needle cannot go, you can use a hemostat and you can crush the calcification. Just crush it, not remove it. So when you crush it, will be some crack between calcification. Then you can put your needle through it and you can finish your anastomosis, okay? When you do distal anastomosis, some people, they do like this kind of one, they do a distal AV fistula. Because you see, the runoff is very poor here. It's only single vessel runoff, it's very poor. So if you don't have a good runoff, the femdistal, it may occlude it. So some people, they still do that. So after you finish, you suture the bypass to the popliteal, to the tibial vein. So you create an AV fistula. This will create high flow in the bypass graft and prevent clotting, you know. And you can close it like after a week or 2 weeks, you know. You can go either in the vascular, you can go through the vein and put a plug, or you can do small cut and tight, you know. But most people, they do a fistula to keep the graft, if the runoff is poor, to keep the graft up. So again, try to crack your calcification, use CO2 blower, and think about AV fistula. What if we do an angiogram, there's no posterior tibial, like this patient saying, but you don't see posterior tibial? What do you do?
Arterialize the deep veins. Arterialize the deep veins.
Yes, you can do that, but before that, we do something else. We do blind explore, because what happens is there was always occlusion. When you inject, sometimes the artery is open, but there's no, but the canvas will not reach down, you know. So you go blind. I usually go to posterior tibial. This is the best one. So you're going to make a small cut and you expose it, and most of the time you see it open. Or you can use a Doppler. If you see any flow on the posterior tibial, will be enough, you know. This is what I'll do. I get a Doppler or duplex. Even with the angiogram, you don't see anything, do a Doppler. If you see any flow posterior tibia that means open, then you can do distal bypass still. The venous arterialization, this is your last options, you know, before amputations. And success rate, unless if you do it incorrect, because a lot of technical issue is not just like you suture to the deep. Because you just suture it to the deep systems, you see a lot of valve in the foot. So all this blood will go back to the leg, and nothing, the foot still is ischemic. So you have to go distal. You need to destroy the distal vein valves. So the blood will go downward, not upward, you know. And to do that, you have you can use a balloon or you can use a dilator. So you have different technique to do that. So again, you just go to deep venous, deep vein arterialization without destroying the valve will be useless. So again, a lot of technical issue to get a good result, but some people are getting a good result. So this is also another thing you can think about. All right, any other questions? Any other concern? All right, so we can move to the next question. So Muhammad, let's see Zahra. Zahra, you want to take this question? Let me see which one question now. Let me see which one, this one. We finish this one, yeah, yeah. All right, let's get 47. See what is that.
Okay, an 18-year-old man presents with pain after he was struck by a helmet around the left knee during a football game. On examination, the knee is swollen and tender. He is able to move his toes, but has decreased sensation to the foot and ankle. Doppler revealed a reduced posterior tibialis pulse and the absence of dorsalis pedis pulse. The most appropriate next step.
Okay, before we go that, so the 18-year-old guy is athletics.
Yeah, had a trauma.
Has a trauma to the knee, decreased sensation. So most of it has injury to popliteal artery, right?
Yes.
So reveal a reduced posterior tibial is absent of its artery. Yeah. So most of it has an injury because he has a knee injury. So popliteal artery must have been injured, right?
Yeah, and yes.
So how we can make a diagnosis? I'll tell you how we make a diagnosis for popliteal injury here. Let's see what options they have, you know.
CTA.
Best CT angiogram, correct. Why is a CT not ultrasound? Let's go one by one.
CTA, yeah, okay. Ultrasound, it's operator dependent, and it may show us thrombosis or injury, and that's it. CTA, it will show if he has dissection, if he has thrombosis or transection.
Okay.
Okay.
I agree with that, yes, because CT angiogram, you can see more because you need to be fixed. You see, this is not only diagnostic, you think about fixing him. You see, it's different. If it's just like you are not sure, you won't just get, you know, what's going on. He has good pulses, but you want to like rule out intimal injury, maybe duplex ultrasound will be enough, you know. But this guy has decreased pulse, so I need to do a surgery on him or intervention, whatever. I have to do something. Then I need more information, not about the injury only. I need to know how's the inflow, outflow, the length of the injury, how about the injury, how is the vein. So you have to look at all the things. So CT angiogram, I think, is the best. What about digital angiogram?
Digital angiogram, it's invasive, so better to start with CTA because it's next step.
Yes, because I mean, digital angiogram, we don't do it nowadays, rarely, unless you're planning for intervention, because CT angiogram now really almost replaced the CT angiogram. MRI is very good, but again, it's just too much, you know, and it's not our first options. EBI, what about EBI?
Yeah, we can do it with the examination, but it will not be the most appropriate.
Right, will not give us, again, we just give us an idea, we know about it. He's going to tell us it's going to be low. So the ankle breaker index is going to tell us, okay, you have arterial injury somewhere, but doesn't give us exactly where it is, the location. So the reason why all the information will not get it from there. So even all the studies are okay, but the best one way to get all the information so you can fix it will be CT angiogram. And this is what we do really. All right, great, thank you. We go to Muhammad.
Yes, doctor.
Let's go to 48. Okay.
48, a 70-year-old woman presented with a few months history of left foot ulcer. At the time of presentation, she had experienced a myocardial infarction 6 months earlier. Her other risk factors include long-standing history of diabetes. Non-invasive studies reveal a falsely elevated ankle pressure, but her toe pressure was less than 30.
Okay.
Her left foot angiogram showed severe stenosis at the tip of the tibio-peroneal trunk and long segment occlusion of the anterior tibial artery. Endovascular management for the tibial disease in patients with critical limb ischemia is.
Okay, it's before we go. You see the picture here?
Yeah, so this is, this is an old lady presented with a tissue loss with below knee disease mainly.
Okay.
She had trifurcation disease and the anterior peroneal is gone. So yeah, we will start with
like in real life. If you get this one,
in real life, I will try to cross the tibio-peroneal trunk to. I saw good peroneal, good posterior tibial. Maybe we can balloon both, and we give the patient the best of the best of what we can.
And do balloon angioplasty most probably, you know.
Yeah,
the only thing that I think Ali mentioned last time, like this areas, what happened is that, like you see, peroneal is open posterior. You go to the posterior tibia, you just balloon by itself. Sometimes you move the plaque to the side, and you can occlude the peroneal or the anterior tibia. You know.
Yeah.
There's a wide, you know, that Ali mentioned last time. It's better to put two wires, so you protect it. So something there, then you can, you know, or you do kissing balloon, or you can at least you do ballooning after angiogram. You see one is occluded, the other one, and you can go and open it. So this is something you can think about it. Or if you don't want to do that, at least use the main artery. Like target, like here you have peroneal and posterior tibial. So when I get my wire, I try to get it to the posterior tibial because it's more important. Because if I get it to the peroneal, I open the peroneal trunk and then occlude the posterior tibial, it's not good. Because posterior tibial is more important than peroneal. So, so I'll get my wire, try to get to the posterior tibial, and then ballooning. If it's a peroneal occluded, it's okay. It's not as bad if I occlude the posterior tibial, you know. Also, you try you try to go more distal. You see the anterior tibial is occluded distally. You try to open also anterior tibial. So there's a lot of work you can do it here, you know. Yes. Well, let's see what options they give you here. Let's go one by one.
So it's not recommended due to poor result of limb salvage and critical limb ischemia. Don't
Is this
think so.
correct? No.
Hmm?
So
No,
for
no.
angioplasty,
Yeah.
yeah. So it's poor result in what? In critical limb ischemia. What is the poor?
Claudication.
No.
Hmm.
I'm saying and when you do PTA for critical limb ischemia, you have a better result in what? In patency. Patency is not good, correct?
Yes.
But limb salvage is great. You see, this is my point. So the limb salvage is good, even though the patency is bad, because we know they don't stay open. You do commission, it looks beautiful. I'm sure if you come after 6 months, a year, you see they occlude again. But at least you get enough blood flow to heal the ulcer or salvage the foot. So the patency of PTA for lower extremity is not great, but the limb salvage is very good, you know. All right. Okay, let's go next one.
Can be attempted using a primary angioplasty with standard balloons. I think this is
Not what we do every time, right? Okay.
yeah, this is what we do in
Right.
Bologna.
Let's do the next one now.
Can be attempted during using angioplasty only with drug-eluting balloons. Not really. You can use the standard balloon.
None, as I said before, none of them. You see, drug-eluting balloon showed it increased patency. So we go back. You see, with critical limb ischemia, you have to talk about two things completely different: patency and limb salvage. It's completely different, you know. So drug-eluting balloon showed it increased your patency, but the limb salvage is the same as a normal balloon. See, so the reason why it's not, you know, you can use it, but it's not really. None of studies showed it. It's better limb salvage. It's better patency, but not limb salvage. And the moment you see only in the question, that means wrong. There's nothing in the medicine like only, you know.
Yes.
So this is wrong. Okay.
It should include a atherectomy prior to angioplasty.
No. Also, none of the study. Oh, we go back to study. None of the studies showed that adding atherectomy to angioplasty get a better patency. There's another common study now going on. They showed maybe within 1 year you have a better patency. But again, when we talk about critical limb ischemia, we don't talk about patency. We talk about salvage, you know. So even it maybe atherectomy give me a better patency, but the salvage is still the same. The reason why you don't need to spend all this money for a atherectomy or get the same outcome. The reason why you see really we use them in our hospital, you know, atherectomy, because until now we don't have really a strong data to tell us atherectomy give us a better patency than regular balloon, you know, or drug-coated balloon. Okay, what is last one?
Can be attempted only if small cardiac stents are available. No, we don't stent those kind of.
Yeah. We don't stand below the knee unless if you have like dissections, you know, and most of the time if you have a dissection will be long, so you need a long stent. I mean, small cardiac stent. One time I used really small cardiac stent because it was like this lesion, because you see small lesion here. And after I finished, I have a good run off only dissection limit flow. So I use one of the drug-eluting drug-coated stent from the coronary. That works fine. But this is wrong, rarely. But yes, you can use it if you have a localized small dissections, you know. But again, only this is also wrong. The moment you see only the question, this is wrong. Okay.
Yes.
Ali, do you have anything to add, Ali?
See, good evening. I'm following. I use some stents, some cardiac stents, sometimes drug-eluted with the sirolimus cardiac stent, because I think they are better than paclitaxel in these cases. When we have some complications, so you have to resolve it, because here you are saving a limb. So if there is any, if there's any dissection or anything like this, you have to have cardiac stents on the roof and to use them if they are necessary. I agree with you, but sometimes I use them.
Yeah. Last two questions. You are not here, Ali. I think this, when you have a calcification, distal artery, want to distal bypass, is any new trick you can teach the fellow? If you have a calcified
I followed, but I have some problems with the connections. I was wondering
Okay.
because they don't mention the in situ venous bypass for the posterior tibial artery when you had the occlusion of the SFA and the popliteal in the question that you mentioned before, I think 44,
Yes,
45,
yes,
like this.
yes,
They don't
yes.
mention, but the fellows, they have to know that we can use the in situ bypass in these cases.
Yes.
This is for the surgeon, for the vascular surgeon. But if we have some of fellows cardiac or radiologists, I think they use the double approach, retrograde and antegrade with the rendezvous. So they like these approaches. We as surgeons, we go to the option of the surgery when we see images like this. But the cardiologist, because some of our fellows cardiologists in Europe, they do this distal interventional radiology, or some radiologists. They usually use the double approach, retrograde and antegrade with the rendezvous at the popliteal or above the popliteal, using the outback to re-enter to the lumen, or the double balloon to rupture the plaque, and then they pass the wire from one side to the another, and they put stents or balloon all the axis. So there are many options, but for a surgeon, I think when we see images like that, we go directly to surgery. We don't think much about intervention in these cases, because we see the artery, because we know how it is, the plaque. This is contrary to our fellows, our colleagues in cardiology or interventional radiologists who did not see any plaque or did not touch any artery, and this is their problem, I think.
I agree with that, Ahmed. Ali, what about do you do distal fistula? If you do like from distal bypass like this,
you can do it. You can do it to improve the patency. You can do it in some cases to improve the patency. Yeah. Okay. And then you can ligate it in some way, or by direct approach, or you put a suture and you tie it, and you take it out of the skin, and then you ligate it from outside to inside, if you don't want to reopen yeah. That's
what about this one, Ali? This one, the last one, you see the perennial trunk, the one you see it now. You put a double wire, or you just go with one wire?
The double wire technique, and you can go to the anterior tibial artery, and you can try to open it. There are some catheters like Trailblazers of the EV3. You can use this. These are CTO catheters that you can use to reopen the axis. They help you to go antegrade slowly with a wire, 0.14 wire, and they can how I can say, they are like a drop of water in the rock. They open slowly these arteries. It's known as Trailblazer. It's a catheter. It's a thin catheter, Trailblazer. I suggest to the fellows to use it when they are in these cases.
Yeah, I agree with that. I mean, I used it before. It's very nice catheter. I agree with that. Yeah. When you put a double wires, you just put double wire, or you do kissing balloon, or just put double wire and balloon?
You can put double wire, and you can use the kissing balloon. Yeah, because here you can use the catheters that our colleagues in cardiology use them to dilate the arteries. They guiding 6 French guiding catheters. So you can use them, and you can pass from these catheters, pass your balloons down to the arteries, and you can use it. Yeah, double balloon kissing them.
All right. All right. So we can move to the next question. So we don't have waste too much time. Whose turn now? I got lost. Bassam يمكن.
Yeah. Dr. Samer, بس سؤال أخير.
تفضل.
Atherectomy device. Any
Yeah.
clear indication for this or no?
Yes, I was thinking about same things. Yes, you can do it, but will not be by itself. You see, atherectomy is still you have to do balloning, you know. But the second thing you have to think about embolization. So you have to be very careful, very slow. You have to know how to do it, you know. But something localized like that, yes, I may do atherectomy first and then followed with the balloon, you know, because it's very localized area and it may give you better patency. But you see the question they said only, that's why I said it's wrong, you see. Should include atherectomy, should, nothing like should include, no. It can be atherectomy, but not should. Should that mean you have to do atherectomy? No, you don't have to. But I think maybe it is better, you know, because localized lesion, you know. Yeah, all right. Well, let's go to Bassam. We'll take the question number 49. You are there, Bassam?
Yeah, I am here. 64 years old woman presents to the emergency room with a 2-week history of pain and progressive discoloration of right toes.
Okay.
Like in the figure. Okay. On examination, the emergency room physician is able to palpate a dorsalis with his pulse. The most likely diagnosis is blue toe syndrome.
Correct. So it's very easy. It's blue toe syndrome, you know. What do you think is the cause? What is the most common cause?
It's digital artery occlusion.
Yeah, but where is embolization coming from?
Embolization. Or
From where?
Either popliteal artery aneurysm or dissection. يعني dissection, vasculitis. We have the differential diagnosis, but mainly aneurysm.
Aneurysm, right. Aortic aneurysm is most, you know. Also, we see it after interventions, you know, if a patient any kind of iliac aortic intervention, we see that because during the intervention we do ballooning, especially iliac aorta stenting, a lot of trash go down, you know. So also it's common to see after interventions, you know. Do you know how we treat it?
Anticoagulation.
Okay. This is thing. Think about it, but in general, for Bluetooth, because this is an atheroma, it's not a clot, right?
Yeah.
It is mainly, it's not a clot you can dissolve, so you can give TBA or to dissolve it. It's an atheroma, it's a micro atheroma emboli from a plaque, from somewhere, you know, because clot usually clot will be like, you know, major artery, big clot. You really see like micro, you know, clot. So there's really no different treatment, but most people, they give antiplatelets. They think it's making it better because it makes the platelets is, you know, less adherence and you get more blood flow to the toe, you know. Most of the time you end with only skin. Also because this is usually involved the skin, but most usually it's in. So always tell the patient, don't be scared about it. Really you end with losing the toe. Most of the time it can be resolved completely, or you may lose only a part of the skin, you know. But the best way to give antiplatelets, this is what I prefer, you know. Well, let's see what options they gave you here. What they say. What the question asking? What the likely diagnosis is. Right. Okay, let's go here. This is the option.
Digital ischemia due to occlusion of the distal foot blood vessels. Yes.
Okay, this is what you said now. This is not the pathology. Okay.
Yeah, acute aortic occlusion. No, لأنه حيكون more aggressive.
Not only more aggressive, but it has the pulses, right? It has a bit of pulses.
And pulses will disappear.
Intact. So it's not aortic occlusion. Okay.
chronic femoral popliteal occlusive disease also will be the pulse will be absent.
Right. Even though you can see, you can have an atheroma. I mean, you can still have. This is really is not good answers because C, yes, you can have because something can embolization from plaque in the SFA or popliteal. So the artery is open, but it's just like a shaggy artery. It is open, so you can get embolizations. But he said occlusive disease. Maybe he meant occlusion. If it's occlusion, no, because you have distal pulses. Only disease from they can give you that, you know. Okay.
Okay. Superficial femoral artery thrombosis. Yeah, if it is complete thrombosis, also the pulse will disappear. Bilateral iliac artery stenosis. Stenosis, yeah, if it is like shaggy, as I said. But stenosis, yeah, you will have.
It's not a good question, but in general, it's, you know, but the question comes from the aorta usually, you know, or after intervention, or plaque in the shaggy aorta or iliacs, you know. I think this is what I see most of the time. Again, the way I do, I just give and wait. It's very painful. It takes some time. But sometimes it helps. Oxygens, HBO. Well, let's treat it. Ali, what do you think? Anything else to blood?
I think these situations are very, very, very painful, really. The patient pain that it is not supportable. Sometimes you have to use many opioid drugs to calm the drug. In these cases, I think you have to go to the anticoagulation, anti-aggregant, antiplatelets drugs. I use in these cases to inject lidocaine, xylocaine in the artery for the pain that the patient had. Sometimes it works and the pain go up. So you can use it if you want to calm the pain of the patient. Some colleagues use the lumbar sympathectomy if you want also, or you can put epidural catheter to calm the pain for 3, 4, 5 days with some mild doses of analgesic using the peridural.
You meant around the toe? Give it?
What?
You said you give lidocaine where? Around the toe?
No, in the artery. I injected in the artery.
Inside the artery?
Yeah, in the artery. From the femoral artery downstream. So 1 centimeter, 1 cc of lidocaine with 9 centimeter cc of physiologic of serum, of any serum you want, and you inject it in the femoral artery. Other cases, no problem. I had no problem.
Okay.
And I used this technique when I had to do some PTA in patients who are many pain on the table, when you have to manage them on the table and they had pain. You can use this technique or this method. You can inject xylocaine in the artery. You can calm your patient and you go with your procedure more comfortably. For this case, for this Bluetooth syndrome, you can use the peridural analgesia if you want, with mild doses of analgesic for 4, 5, 6, 1 week, as you. It depends on the patient. You can, because the pain is the more difficult element. More difficult element for these patients, and these patients may go out for 10 or 15 days with this pain. So you have to find some way to calm their pain.
Yeah, I agree with that. Yeah, I mean, pain is the main presentation for these people.
Yeah.
It's very painful, you said, yeah. But lidocaine through the artery, you don't get any arrhythmia, any problem from the heart with
No,
this
no, I don't,
lidocaine?
nothing, no.
Oh, okay. That's the first time. All right.
As I said, I use it sometimes when I do some procedures, PTA procedures, in some patients who had pain. I inject xylocaine in the artery, diluted, and I can calm the patient and I can work more comfortably with this, with my procedure.
Yeah. All right. Well, let's go to the, what question now? 49. Wow. So we go to 50. Okay. 50, who is that? Ahmed? Want to take this question, Ahmed? Here we are. You still there, Ahmed?
Is it me?
Yeah.
Okay. A 74-year-old man presents to a pediatrist with dry gangrene of the left fourth and fifth digit lasting 1 month. He has a medical history of hypertension, claudication, current tobacco use, dyslipidemia, stage 3 chronic kidney disease, and type 2 diabetes. On examination, his femoral pulses are present, but popliteal and the distal pulses are absent. The best immediate option for managing this patient is.
All right. So 70 years old. So he has a gangrene. You can see, let's see the picture. So he has a frank gangrene here, second and third toes. Okay. You see some infection, some cellulitis here. The problem is he has at stage 3 chronic kidney disease. Okay. He's diabetics. Femoral pulse are present, popliteal, distal pulse are absent. So mostly he has a distal disease. So what we do in this case, like patient comes to the clinic, mostly has a monophasic Dopplers, he has a gangrene toes. So what option, what we need, what we do? Let's go one by one, see what options we have. Okay, let's start with first one.
Option A, urgent left fourth and the fifth transmetatarsal amputation. I don't think so.
Why is that not? Why is not? Because you didn't fix his circulation, right? So you just do amputation will not be enough, right? So, and it's not like a wet gangrene to an urgent, still is not too bad, it's not like looks more dry gangrene. So it doesn't have to be like that. Okay, so let's get the next one.
B, obtain a CT angiogram. That seems useful.
Yeah, but remember what the problem here, patient has a chronic disease, chronic kidney disease, right?
A dialysis.
I cannot hear you well.
With coordination with the nephrologist, we may do the CT, and if he obtains it, if he allows it,
no.
The nephrologist say yes.
Yes, this is really a misconcept from the interventions. None of the studies show doing dialysis after giving contrast will take the contrast out. So really, I hear that always from interventionists, give it and do dialysis. None of the studies showed really it helped. So it's useless. And we stopped doing that long time. And if you talk to nephrology, they tell you the same things. So dialysis after CT angiogram will not take the contrast out. The contrast already damaged the kidney, it'll be too late. So reason why, so we don't get the CT angiogram. You see, CT angiogram required at least 130 to 150 cc, too much contrast, And if you have to do it with the contrast, I would prefer to do an angiogram because you can do the whole angiogram with like 20 cc. But CT angiogram requires a lot of contrast, Unless a situation like life-threatening, you think patient has a bowel ischemia, you want to rule out, SMA occlusions, something like you cannot rule it out with other, or you want to rule out bowel ischemia or rule out dissections, patient comes with a trauma, then I may take a risk. But this patient, I will not put him because if you give him CAT scan, it must be you can damage his kidney. So I will not get CAT scan on this guy. So this is the reason why we don't do that. And again, and to protect the kidney, they give you, the only thing to protect the kidney proof is just hydration. Everything else is none of them they prove, Like you give him like a ringer lactate, it doesn't work, give them what we call it medication before it doesn't work. So the most important to protect the kidney is to stop all nephrotoxic medication and well hydration. Well hydration is the best. And many times we take patients for interventions and with GFR is low like 30, and after procedure even GFR improve, even though we give some contrast during the procedure. The reason why, because patient is well hydrated, and most probably his GFR is low, part of it because of dehydration. So hydration really is the only things prove that it protects the kidney. Anything else will not work, But again, don't get CT angiogram because too much contrast. If you want to do it, do an angiogram right away. This is less contrast because you can dilute it. And I think Ali, he can agree with me. Sometimes you can do the whole leg angiogram with maybe like 15 cc. There's not much contrast. But CT, you need a lot of contrast. All right, let's go to the next one. C.
Admit to hospital for intravenous antibiotics.
Yeah, it's not a bad options, but we'll keep it there. Let's see what next options.
Non-invasive duplex imaging and local wound care.
Local wound care and non-invasive. So what he's saying that here, we think he has arterial duplex. So we know he has an arterial disease. We want to confirm that. So you get a duplex because you can get CT angiogram. So I think this is not a bad options. A local wound care, just antibiotic because I don't see wet gangrene. So it could be a possible. Let's go to last one.
Immediate diagnostic angiogram with planned femoral popliteal bypass.
You see, we don't know what's the disease. So just to go say fem-pop bypass, we don't know where's the level. So this is wrong because we don't know where's the level of disease. They didn't give us any information. And again, diagnostic angiogram is not the best options, with the contrast. So really what we do in this real life, if I got this patient, yes, we admit him to the hospital. We get a duplex just to see where's the level of the occlusions, or how bad the occlusions. And then we do as a CO2 angiogram. This is what usually we do. We do a CO2 angiogram. And even with CO2, sometimes it's very hard to see this artery. So we still give contrast, but at least CO2 will limit our contrast. We just only when we go below the knee, we give some contrast to see better because sometimes it's very hard to see below knee or tibial artery with the CO2. So usually what we do. So I don't need a CT scan. I don't need an angiogram. Just get duplex ultrasound, confirm the problems, the arterial occlusions, and then take him do a CO2 angiogram intervention if needed, and they do amputation. Of course, you still need antibiotics, So if I have two options here, I think I will go with that. C and D are both correct, but I think maybe D, it's more, appropriate. But even C is correct. You still have antibiotic. I mean, it doesn't have bad infection, but still need antibiotics. Ali, you want to add anything about that?
No, I agree with you. Because we can do our operation only depending on the new generations of duplex, color duplex.
Yeah.
So there is no need to give contrast in these cases if we have a good mapping of the arteries, so we can do our bypass with no problem, without any problem.
That's true.
We use also these cases for the carotid. If you remember, we discussed it before. In some cases, we can do our carotids without any angiogram, only depending on the color duplex.
I mean, if you have really a good vascular technicians, sometimes they do lower extremity duplex. I saw some duplex study. It's like an angiogram. It's beautiful.
We used to do it by ourselves, really, here in Syria.
Okay. Yourself.
We do our color duplex and we do our interventions.
Yeah. And even I sometimes, it always takes sometimes, but really if you do duplex study, sometimes get more information than CT angiogram because you see stenosis, you see with the duplex, how significant. You see the velocity, if it's like significant or not significant. Yeah. You see in the CT, you just see stenosis. Is this significant, not significant, really? And even some people, they do intervention guided by ultrasound. You don't use X-ray CR, But again, you have to have a really good, vascular technician, and they can do duplex USFA, and you go through, you do balloon. Even it's better because you can size the balloon. You see how's the result after you do ballooning, how's the flow. You re-measure the velocity. So really, it's much, much better than whatever we do. But the only thing is time consuming, and you need a good vascular tech. All right, so let's go to next questions. Now we go to Ahmed. Mumtin. I'm talking to you, Ahmed. We get Ahmed, another Ahmed. Okay, that's good.
Okay.
In the table, the patient with the highest 1-year rate of major amputation utilizing the SVS threatened limb classification system, the Wi-Fi system.
All right.
The one
This is
presented by
number
last
one.
ago.
Huh?
The one presented by Muhammad a few weeks
Muhammad,
ago.
what is Muhammad answered? Muhammad, you answered.
Yes, doctor.
So what is the 1, 2, and 3 for the wound? Remember?
Yeah.
Anyway, it's just simple. I mean, the more higher number is more complicated. Simple like that, right?
Yes.
It's a way. Even if you don't know, I'll tell you how you can answer it. No. Sorry, Hamad?
Yeah, they want to describe the wound in the question,
Right.
yeah.
But let's say you don't know about Wi-Fi. You want to answer this question, right? We know the higher numbers that mean the wound is worse and the ischemia is worse, the infection is worse, correct? Because they go 0, 1, 2, 3, right?
Sure.
So if you go to the last one, you have 1 and 0. So the 0 is wrong, so but you still have one of the 3 answers, correct? B, C, and D. Okay. You go to the ischemia, you have 1, 2, 3. It should be 2 or 3. So you go, now you have B and C only. So now to come to the wound, 1 and 3, 3 is the worst.
Yeah.
So the end is this one. So this one is the worst one, really, C.
Yeah.
You see? See how you answered without knowing what is classification.
Sudoku.
But in general, I mean, it's really simple. I mean, it looks complicated. The one is a small ulcer, 2 is more like deeper ulcer or limited gangrene, and 3 when you have like an extensive ulcer or extensive gangrene. It's the way they do it. Ischemia 1, 2, 3, it depends on the toe pressure. You said it should be more than 70, so like 40 to 60 they consider 1. I think 30 to 42 and less than 30 they consider 3. So the more ischemia, the high number. Foot infection, again, mild, moderate, and severe, 1, 2, 3. So it's really not complicated, but in general, always in higher numbers, that means it's the worst outcome. It's the way you can answer it, okay? All right, so let's see what the answer here. So we decide to be 3, 2, so be C, C. So we already answered it. So again, guys, maybe you need to read it because maybe in the exam you get a lot of questions, maybe difficult more questions. Maybe they give you a scenario, tell you what's the classification, like superficial ulcer, mild infection, toe pressure is like 30. What is Wi-Fi? Then become more complicated, All right. Well, let's go to 51, 52. Let's go to Zahra. Zahra, you still with us?
Yes.
Okay, want to take this question?
76-year-old man is emergently transferred to the hospital with sudden onset of bilateral lower extremity paralysis. On examination, mottling of both lower extremities and absent femoral pulses are noted. The most likely diagnosis is Lariche syndrome. I think.
Yeah, but this one, they said emergently, right?
Okay.
And so this something happened suddenly, and we lost both legs. So we're talking both legs. So that means it's in the level of the aorta.
Yeah,
because,
acute MI is not the option, not the
right.
answer. B, acute aortic occlusion. Yes, most likely. Acute spinal cord infarction. He has mottled and not palpable pulses, so no. Acute femoral popliteal occlusion, no. Acute right iliac occlusion, no. So B, acute aortic occlusion.
I think the only thing, but unfortunately, this being confused with acute spinal cord infarction. I saw a patient who came to us with a late pathologic ischemia because he had an aortic dissection. He's a young guy. I think guys who work with me, they can remember him. And he have a sudden, because of the aortic dissection, he has sudden, aortic occlusion. He has sudden, paralysis of the lower extremity. that they thought he has spinal cord ischemia, MRI, because nobody examined him, unfortunately. Nobody put the hand to feel the pulses. You know how the ER. This is a common mistake, you know. And I saw it already more than one in one time. The problem, the moment that the patient comes with a sudden paralysis, the only thing that the ER think about, you know, spinal cord ischemia, you know, they start getting MRI and everything. They see something MRI, they wait. And unfortunately, by the time they discover this is an aortic occlusion, you know, patient will be already too late, because you see MRI takes too long. So what happens, they admit him to the neurology. Next day they get the MRI get the result next day. So after 2 days, they discovered, oh, it's not and spinal and aortic occlusion. By that time, the legs would be dead, you know. I think I remember at least I saw 2 cases like that. So you have to be very careful. Always examine the legs and be sure to check the pulses. If you check the pulses, very easy. Acute spinal cord ischemia infarction should have a normal pulses, you know. The moment you lose the pulses, that means it's aortic occlusion, you know. Yeah, unfortunately. All right, well, let's not waste too much time. It's very simple, because I think we have maybe 3 more questions, so we can finish the session today. We go to Muhammad. You want to take 53?
Yes, sure, doctor.
Okay.
53, 67 years old, male smoker with insulin-dependent diabetes, presents with progressive hind foot and forefoot gangrene after multiple failed superficial femoral artery and tibial endovascular intervention. No revascularization option is present, and major limb amputation is recommended. The best predictor of successful healing of below knee amputation is.
So you see, that is why the what's name, the orthopedic, they keep calling us, you know, for this reason. So this should know what is the best way to predict the amputation going to heal or not below the knee. Really, the only one you see, when think about it retrospective, what makes a below knee wound dehiscence or doesn't heal? What the main issue problem usually?
Usually skin, yeah.
Skin to skin. You see, remember, skin. Because the skin get necrotic, and that's muscles, they never get necrotic. Muscles is usually very, very, you know, well supplied. I mean, rarely you see. So most of your failure because of the skin. The reason why I always tell you guys, when you do below knee amputation, you have to be very careful how you handle the skin. Because the moment you get the skin ulceration, necrosis, then your amputation, even the muscle down looks beautiful, it will not work. Because what happens, if you're going to use prosthesis, you cannot depend on second healing. You cannot like leave the wound open, wait for a granulation, and put a skin graft, because it'll be very fragile, the skin. Even you cannot put a prosthesis. So you have to have a good skin healing to get really good stump for. So the skin is the most important part of amputations, you know. So it's very important when you do amputation, don't use too much movie, close the skin, handle the skin very nice, you know, be sure there's no tension in the skin, because the moment the skin failed, the amputation, the whole amputation failed. So the only way to know how the blood flow to the skin is by TCBO2, because all other things, they tell you how much flow to the muscle, none of them tell you how much flow to the skin. Because you can have a good flow to the muscle, but he has a small vessel disease. So then the blood, yes, will get to the muscle, but doesn't get to the skin. So you can still get a skin necrosis. So usually what we do, we measure the skin, you know, oxygenation, which is called TCBO2. And it has to be more than 40, as mentioned in the questions, you know. The only problem with the TCBO2, it has to be done. It's very difficult, very sensitive to the temperature of the room. So it has to be, you know, calibrated. You have to do like a referral point. You have to do 3 points, you know. It's very sensitive, but also there's a lot of false positive, false negative. It has to be done right to get really the right measurement. But in general, this is the reason why you see when we look at the patient, we look at the skin. If the skin is warm and had good hair, then we say, okay, this will work, you know. If the skin looks cold and he had a hair loss, then we knew that this will not heal. So again, the most important is skin. All right. So I think this gives us desire. Let's go one by one, Hamad.
Yeah. A, patent common femoral artery and profunda femoris artery. Allah, doctor.
Usually is not enough.
Yeah. B, transcutaneous oxygen measurement of 40 milli equivalent of at the distal calf. هذا اللي يخطي هذا الجواب دكتور. بس يعني أنا I was between A and B, but in distal calf I don't know.
Yeah, distal calf. You can take a muscle from distal.
Yeah.
Right? Because we do posterior flap. Posterior flap almost, you see, we cut the foot just below the knee, but really when you cut the skin, you cut almost down just above the ankle because you need a long flap to turn it up, you see?
Yeah.
So really, of course, if the infection going above the ankle, like for maybe 10, 15 centimeters, then you cannot do amputation because the posterior flap will be infected, The camofemoral profunda is enough for above knee, but below the knee, it's not. But again, you can't depend on arterial angiogram. You have to see TCBO2. But in general, for below the knee, you need the SFA to be open already. Profunda and femoral is good for above knee. But this is in general. But to be more specific, you have to do TCBO2.
Okay.
Next one.
Temperature measured of 90 Fahrenheit at the distal calf. No, the transcutaneous is better for.
Yeah.
Absolute ankle pressure of 60 millimole.
No, this gives you the muscle number. All this gives you the muscle. If you want to know the skin, so this will not. Yeah, it doesn't matter. ABI, 60 or above or less will not. Because again, you can have good flow to the muscle and you have the skin. It's completely different situations, The reason why sometimes we do bypass successful intervention and still also doesn't heal because you have a small vessel disease. The reason why I said before, if you have diabetes and hemodialysis, patient hemodialysis, the renal failure, this is a very bad combination because patient on dialysis, usually they develop a small vessel disease. So even if you do successful bypass intervention, they still end with the ulcer doesn't heal because you have a small vessel disease. So you have to look at that. Okay. And the last one.
Can fluorescence using intravenous injection of the fluorescence dye? Fluorescein dye.
I don't know. I never saw it really.
They mention it a lot, doctor, in bowel ischemia. If you are in doubt.
Yeah, bowel ischemia, yes. Bowel ischemia, I use it. Yes, we use fluorescein. Yes, but not in the legs. I never saw it in the legs really. They have this what we call it. You see, we have that what called we use in our hospital. It show you the blood flow to the skin. It depends on the floor, but not fluorescein. Yeah, we give fluorescein. Yes, this is the one. Yeah. It gives you like a red and yellow and the blue colors, I remember what's the name. So we do it before and after. It shows you how much flow. So you give fluorescein, you give it through the vein, and then you wait, and then you do it before, you give it, then you give it, and you do intervention, you inject it after, then you do it after injection, you do the camera. What is the name of this one? And then show you what blood flow improve or not, The
wood lamp.
But usually they for
the wood lamp.
Like a camera. No. Wood lamp is the hand you hold. It's like a camera. It has. We have it in our house already. Once time I saw it, and we use it maybe 2 or 3 times. Some people now they use it for studies. To see how the success of your intervention, because what help. But this is give you flow to the muscle mainly. Is not it is an area, but it's not for level of the amputation. It's different. Again, like you have an ischemic ulcers, you do the fluorescein test before. You see the around area will be black, and after you do intervention, you do it again. If it's turned to red, that means you increase blood flow because sometimes like an angiogram, you don't see direct blood flow, but you see collaterals. So when you do your proximal intervention, you increase blood through the collaterals. So to see how much improves the wound, then you have to do the fluoroscopy study, And So just remind me, we can use it. I think I saw it here. For some reason, the company brought to our hospital. We used it a couple of times and they forgot to take it, you know. And I still see it a couple of times and we use it. I don't know if Sam remember it, but we use it a couple of patients. It's very nice, really. But it's not for amputation. This is just to see your success after endovascular intervention. And also the general surgeons, they use it for bowel ischemia. Instead of wood lamp, they use this one, you know. I think they called it SPY, I remember, called SPY. The SPY, S-P-Y, SPY. Yeah, called SPY, the machine. All right, well, let's go, guys, to finish. Oh, we're late today, 9:30, but you need to finish this session today. I think this is the last question. Let me see, the last question. Oh, it's 2 more questions. Okay, but Sam, you want to take it very quick?
Yeah, let's go.
Let's go to this one. Okay, with Sam?
54, I think. Yeah.
Are you there with Sam or you left?
Yeah, I'm there. Can you hear
I can't hear you. Your voice very far.
I am here. I'm sharp. Is it okay now?
No. Ahmed, you can take it, Ahmed.
Yeah, okay. A diabetic 75-year-old man, he presents with a plantar wound. Yeah.
Okay.
He has relatively healthy and patent femoral and popliteal arteries. ABI is low, 0.35. The tibial angiogram is shown. The procedure that would have the highest chance of expedite and longer term wound healing would be.
Okay. Let's see what he has. He has a popliteal occlusion and stenosis here. It's popliteal here. As far did not show you proximal, that means you have to presume everything is open proximal. Okay. He has a peroneal here. Peroneal give you the posterior tibial here. Distal have posterior tibial. You know, and you have a large wound. You know.
Yeah.
What they ask you, what is the highest chance of expectation of expected and long-term wound healing? Okay, they didn't tell you what your next step, what your best, you know, what is the best one give you the best chance of healing. So in general, they want to tell you is the bypass or endovascular. What do you think?
Bypass below the knee is not that good. Yeah.
Not that good or is good? It's better than endovascular or endovascular is better?
Endovascular and below knee.
Endovascular below the knee, yes, we do it. But look at that. It's so big. Does they ask you, not they ask you what the best, what the next procedure, what to give you the highest chance of long-term wound healing. Because the bypass, nobody, not everyone agreed that, you know, that the long-term wound healing and less of recurrence, long patency, of course, bypass. Nothing like a bypass, you know. Yes, you can try endovascular first. It may work at the wound healing, but this large wound, if you want to get the patient, the best option would be bypass. What your next option, you may do endovascular first, try to recanalize it. But if you want to give the best options, then bypass. Okay? And the bypass will be from popliteal to posterior tibial, like here. See posterior tibial, get peroneal, posterior, popliteal, posterior tibial, okay? So you have to look at the question carefully, see what they're asking you here. So what the highest chance of expecting long-term wound healing? Of course, nobody can argue about bypass, you know. So they give you all this option, tibial, antegrade, retrograde, femoral posterior bypass, saphenous vein, popliteal posterior bypass, saphenous vein. Femoral, you don't have to go to femoral because popliteal is face open. So it should be popliteal to posterior tibial. Prosthetic graft, we don't, prosthetic graft only if we don't have a vein or, you know, we don't have like small saphenous vein. I mean, prosthetic graft should be the last option. So I think the best option for this one, just do a bypass on him, okay?
Okay.
But if they ask you what will be next step, you know, you can say, okay, the intervention. But if they put this question, then this should be, okay?
Oh.
All right. But Sam, you still far or are you answering now? Let's get the last question.
Can you hear me now? Hello?
It's very slow now, computer. And the computer got tired. Here we are. Oops. I don't know what happened here. Sorry, guys. Where we are? No. I wish. But Sam, you're back? No.
Yes.
Zahra,
I'm here.
you want to take the last question? Oh, sorry, this does not keep going, moving.
Yes, Doctor.
Let me find it for you. Just keep moving. Let me go slowly. Okay, the last questions. Can you see it?
I can see the answer, not the question.
Okay, that's good. Make it easier for you. But anyway, she's answer was not important for me. It's a discussion. The reason why
Yeah.
I'm not paying too much attention to the answer. I don't care. It's not. I'm not testing your knowledge, guys. You just need to learn, from discussion. The reason why anyone has a question, please ask me. All right, this is the last one. 69.
A 69-year-old patient who has been on hemodialysis for 10 years underwent amputation of the second and third toes of the left foot for wet gangrene.
Okay.
Pulses are non-palpable.
Okay.
APIs are non-compressible. Absolute toe pressures are 70 millimeter mercury. Based on these findings, it can be determined that.
Okay.
So
this
it
patient
seems
has
that even the big toe. It seems that even the big toe started to be ischemic and gangrene.
Right.
And
But
the wound
let's
is clean.
look at this wound. Okay, you're in the clinic and get this wound. Okay. How is the granulation? Is good or bad?
The granulation is good.
Okay. So what's that tell you? And tell you it's good blood flow or no? Blood flow, right? Because you never get this granulation unless you get blood flow.
Yeah. And 70 toe pressure is good as well.
Yeah. So really, this patient even has no pulses, but yeah, you can get blood flow because I see good granulation tissue. The ischemia on the toe, don't worry about it. This is from dryness, and because the bone and tendon here. So this is the expected, So this one, I don't need to get more. Why need to get anything? It's beautiful blood flow. Even if it's tibial are occluded, whatever. And toe pressure is 70. 70 is almost normal. We say normal above 70. So he has a good blood flow and good toe pressure. I just do local wound care. I don't need to do any intervention or any study on him, I think. You agree with that?
Okay, yes.
Yeah, because let's see what options they gave you. Oh, it's not moving now. All right. See, you go right away. They keep giving you the answer. But anyway, it doesn't matter. Let's go one by one and see what they say. Okay.
A, lower extremity arteriogram and possible angioplasty would be beneficial for this patient, as the wound is good granulation tissue. We said we don't need to do further. A CTA of lower extremity will help identify a tibial target for bypass. We didn't decide to do for him bypass or any procedure. See local wound care and close observation offer a high probability of wound healing. Yes, we need to do wound care. Lower extremity bypass using native vein increases the chances for limb salvage. No, we didn't decide to do any revascularization. A primary below the knee amputation decreases mortality in this patient. No, the wound is clean, not infected. Yani too early to decide for amputation.
Amputation is increase your mortality in general, because they're just talking in general. It's a general statement. Primary below knee amputation, if they said increase mortality in this patient, yes, the answer will be yes. Because this is, they're not saying they're going to do it, but this is a general statement. So primary below knee amputation usually increase mortality, because patient become less mobile, he can take a pneumonia, he get a sacral ulcer, get an infection. The moment you do amputation, we discussed that today in our morning, round, it increases your mortality. and increase the chance of contralateral also below knee amputations. So this will be the wrong answer. So just wound care because the wound looks good. So again, guys, when you get the question in the exam, just imagine you're in the clinic, what you do. Just be realistic. Don't worry about what the answer, what the best to be done. Just imagine you're in the clinic, what I'm going to do with this patient, and you'll be fine. I think we're done with this session. Anybody has a question? Because we're done with lower extremity for good. We're not going to go back to lower extremity. So lower extremity is not difficult really. It's not like much trial and studies. We don't have, you see, we don't have like carotid. It's more like really bread and butter, what we do every day. And I don't think anything really specific about it, you know. Any question from anyone?
Dr. Samer, بس the patient with the long segment occlusion from
Yes.
SFA to the trifurcation below. We said that the bypass would be from SFA to a posterior tibial, and then you suggested doing the fistula. So the target is a salvage to below knee, not to the foot.
The salve foot, because he has a toe amputation. You need the wound to heal. So when we talk about foot, salvage the foot, that means we want the wound to heal because the wound doesn't, the next step you can do below amputation, correct? So when we talk about limb salvage, that means we need to salvage the foot by letting the wound heal. If the wound doesn't heal, the next step is going to go below amputation.
But with this fistula, result in a steals from the foot?
Yes, it's still a steal, but the see is you have to think about it is many ways. The most important, it doesn't really get too much steal, you know, but it keep your graft, because if you have a low outflow, you know, or very poor outflow, and you have blood going very high from the femoral all the way down, the vein bypass will be clotted, you know, in about a week, you know. So the advantage of fistula is that relieves the pressure. You don't have very high pressures, you know, in the graft, because the graft getting all the blood through a very small channels, you know. So with this high pressure, you have a stasis, right? You have a huge amount. Imagine you're in the highway and you have 5 lanes and suddenly become 1 lane. What happened with the car? They cannot drive like 50 miles per hour. They have to slow to 10 miles, right? So the same what happened with the blood. When the blood comes with the vein, which the vein is big, and suddenly has to go through narrow only 2 millimeter or 1 millimeter artery, everything going to slow down. So the RBC, the platelets, everything has to slow down their speed. Then the moment the blood slow down, you get a clotted. This is normal. This is the way we are, you know. So if you do a fistula, at least like you make like an exit. So you have a highway, you have 1 lane, but you make an exit. So yes, the cars are getting out of the highway, get less blood, but at least the way is still open, you know. So you think about like this way, you know. We don't use all the time, but unless if sometime we feel that the blood flow is not very good, because again, the disadvantage is still also, you know, blood, but still you get blood flow out distal, you know.
Yeah.
And then we close it, because after a while, then the artery will dilate slowly because you get more blood. So after like 2 weeks or 3 weeks, the artery will dilate enough. You have enough blood flow, your suture healed. Then you can go on like it the fistula. We don't do it all the time. Only we do it if you have a poor runoff.
Okay, thank you.
Okay.
Oh.
Any other questions? All right, guys, I think we're done. Sorry, today we kept you a bit longer because you have to finish it, and then we'll meet next week. All right, take care. Have a great night, everyone.
Thank you, Doctor.